A very late good evening to all my dear MOS members and the ophthalmic fraternity who have joined tonight. This late show of our e-journal club. MOS Research, e-journal and e-library committee initiative. This is going on month to month on a regular basis. And the brain behind it is Dr. Vaishal Kenia, the chairman of this committee, and aptly supported well by Dr. Parul Deshpande. Well, every month we discuss a topic in detail, threadbare. Today we have an expert faculty, Dr. Pramod Bhende, my alma mater, from my alma mater, that is SN Shankar Nethralaya, and also Dr. Preetham Samant. He is also from Shankar Nethralaya, but is an in-house consultant of MOS. Also, we have our Nehali, who is going to present on endophthalmitis after cataract surgery and the practical risk management to mitigate the risk. So we also have Dr. Sen Gupta, who is the statistical analyst and the co-chairman of this committee. And so all the best. I hand over the thing to Dr. Vaishal Kenia for the further proceedings. Welcome all the faculty and the panelists also. And all the best, Nihali.
Thank you very much, Jignesh sir. And this month-to-month meeting has been a great work by Dr. Parul Deshpande, who has put in a lot of hard work to make this meeting. And today we have Dr. Rajesh Joshi and his residents presenting a very interesting topic of cluster endophthalmitis. And we have none other than Dr. Pramod Bhende, who would comment as a discussant, and Dr. Preetham Samant, who is a very senior vitreoretinal consultant. So it will be very interesting to talk and discuss a cluster endophthalmitis, which is very dear and an interesting topic to all of us. So without further ado, I open the journal club meeting and ask Dr. Parul to initiate the meeting.
Great.
Parul, you are on mute.
Yeah, so Dr. Joshi will do the needful this time, Vaishal. So let him, yeah.
Good evening, one and all. Today we have a very interesting article to discuss in our journal club, but no one wants to happen that in our routine practice. To answer our queries and throw light on the article, we have renowned vitreoretinal specialist, Dr. Pramod Bhende, who is a director of vitreoretinal services in Shankar Nethralaya and has numerous awards and original articles to his credit. His area of interest is surgery in retinopathy of prematurity, diabetic retinopathy, and combined procedures involving anterior and posterior segment. Welcome, sir. Dr. Preetham Samant is our own MOS member, fellow of Shankar Nethralaya, and presently president of Bombay Ophthalmological Society. I also welcome Dr. Sabyasachi Sengupta, a VR surgeon, and Dr. Maninder Sethia, who will be joining, I think, shortly. And without taking too much of time, I request Dr. Nehali to share her presentation and start the procedure.
Good evening, everyone. Is the presentation visible?
Yes, you are audible.
Yes. Good evening, everyone. The topic for today's journal club is clinical features of endophthalmitis clusters after cataract surgery and practical recommendations to mitigate risk, a systemic review. My moderators were Dr. Pramod Bhende sir, Dr. Vaishal Kenia sir, Dr. Preetham Samant sir, and Dr. Parul Deshpande ma'am. As we all know that post-cataract endophthalmitis is a rare but serious post-operative complication which impairs the visual prognosis of the patient. At the system-wide level, the incidence of post-operative endophthalmitis varies across centers from 0.28 to 1.6 per thousand cataract surgeries, which may be due to varying resource availability and the aseptic protocols defined by the national regulatory agencies. Endophthalmitis can be caused both by endogenous pathogens, such as in those with compromised immune system, or exogenous pathogens from contaminated surgical instruments, fluid solutions, and surgical environment. The aim of this study is to systematically evaluate the literature on the exogenous transmission of pathogens via cataract surgery, with a focus on various routes of transmission and practical strategies to manage and mitigate the risk of endophthalmitis outbreak. Systemic literature searches were performed on Ovid Medline, Embase, and Cochrane Central using keywords and subject headings to identify relevant published articles. The study duration was from January 1, 1990 to August 23, 2020. All original studies with at least 5 participants and studies which reported on a plausible pathogen transmission to a patient during cataract surgery with a confirmed or suspected etiology and clinical features of endophthalmitis were included in the study. All forms of cataract surgeries were included. A total of 4,735 records were identified through database searching, and after abstract screening and removal of duplicates, 117 articles were assessed for full text, and of them, 24 articles were selected for the study. The baseline characters of the included study were as follows. The studies were categorized on the basis of the possible mode of transmission into intraocular solution studies, contaminated operating room, contaminated surgical instruments, contaminated topical drops, contaminated intraocular lenses, contaminated autoclave solutions, and contaminated cotton wool swabs. 10 studies were grouped under the intraocular solution category, 3 studies under the operating room, 4 under the contaminated phacoemulsification machine study, 2 under surgical instrument, and 1 each in topical anesthesia, intraocular lens, autoclave solution, and cotton wool swab study. These studies were taken from all over the world, and most of them were single-center study. The most common procedure performed was phacoemulsification. The treatment protocol used in the various studies were as follows. There were 2 studies which used preoperative antimicrobials for prevention of endophthalmitis. That were the SACRA study and the G study. The details for the rest was not available. Intraoperatively, 4 studies used antimicrobials in the form of cefuroxime and gentamicin. The details for the rest was not available. Postoperatively, for treatment of endophthalmitis, antimicrobials were used in the form of oral, intravenous, topical, subconjunctival, intracameral, and intravitreal antimicrobials. Intravitreal antimicrobials were required in 228 eyes, that is 87% eyes. The details were not available for the Sunshine group of study. Otherwise, all the other studies gave antimicrobials to almost 100% of the eyes treated. Intravitreal steroids were given in 68 eyes, 26%. As can be seen, the studies that are highlighted in pink, these were the studies that had given intravitreal steroids, and approximately all the studies gave the intravitreal steroids to 100% of the eyes that were treated. And it can further be seen that repeat vitrectomy rates were 0 in all these studies. Vitrectomy was required in 157 eyes, that is 60.2%. Repeat vitrectomy was required in 26 eyes, that is 10%. And enucleation or evisceration was required in 27 eyes, that is 10%. The rate of enucleation was highest, that is 100% in the Tabara study, and 80% in the Mirza study. That was in this table, the causative organisms were listed, and causative organisms could be isolated from both the patient sample and the source of transmission. Both bacterial and fungal organisms were isolated. The Bukta study, Gangar study, Sakar study, and the Tabara study that are highlighted in yellow, they incriminated fungal pathogens. The rest studies isolated bacteria from the patient samples. The mean time of presentation was 13.4 days, ranging from 1.3 to 46.3 days. The visual acuity presentation was about counting fingers, and at last follow-up, it came up to 20 by 430. It was also noted that patients with diabetes had worse outcomes, that is counting finger, at the final follow-up compared with patients without diabetes, that is up to 20 by 160. Here again, as can be seen, that certain studies did come up with a good visual outcome in the final round, like the Aksaya study, which is highlighted in red. It's the presenting visual outcome was the presenting vision was hand movement, and it improved to up to 20/40 on the final follow-up. Or the Hoffman study, the next highlighted in red, in which the presenting visual acuity was hand movement, and it came up to 20/20 on the final follow-up. Both these studies had bacterial causative organism. The studies that are highlighted in yellow are the studies which had incriminated fungal organisms as a cause of endophthalmitis. And in all these studies, we can see that the final visual outcome was poorer than the presenting visual outcome. There were 10 studies in which contaminated intraocular solution was the source of endophthalmitis. These studies included a total of 128 eyes. The mean age of presentation was 71 years, and the average time of presentation was 14.5 days, ranging from 2.5 to 31.3 days. The baseline visual acuity was 20/800 on Snellen's, and the final visual acuity was 20/500. It was also noted in these studies that the final visual acuity in diabetic patients was much worse than in non-diabetic patients, though statistical significance was not given. Intravitreal antibiotics were in treatment. Intravitreal antibiotics were given to 87%, with the intravitreal steroids given to 22.1%, 27 patients. Vitrectomy was required in 121 patients, that is 65.3%, and repeat vitrectomy was required in 121 patients. Enucleation or evisceration was required in 127 patients, 5.5%. The cause of contamination. Several studies suggested contamination during manufacturing procedure. Notably, the identification of contaminated viscoelastic in the study by Roy et al. Led to product recall by the manufacturer. 9 out of 10 studies were able to isolate organisms from the ocular specimen, and 6 studies were able to isolate the organism from the source. The most common organism isolated was Pseudomonas species, followed by Stenotrophomas maltophilia. There was multiple strategies to mitigate the risk. Overall, the authors advised against assuming that pre-sterilized products have no associated risk. Compounded medications and commercially available products are sometimes a source of an outbreak, and clinicians must stay vigilant to ensure proper sterilization before use. In 3 studies, the cause of endophthalmitis was a contaminated operating room. These studies included 44 eyes. The mean age of presentation was 60.2 years, and the mean time of presentation was 7.32 days, ranging from 6.95 to 8.80 days. The baseline visual acuity was hand movement, and it finally came up to counting fingers. There were 15 of 35 patients, that is 42.9% patients, who had no perception of light at the final follow-up. Intravitreal antimicrobials were given to all the patients, that is 44 patients. Intravitreal steroids were given to 43.2% patients. Vitrectomy was required in 15.9% patients, and repeat vitrectomy was required in 2.3%. 31.8% patients had to undergo enucleation, that is 14 of 44. The cause of contamination was said to be the operating room environment, and was presumed to be contaminated by air conditioning systems in 2 studies, presumably due to accumulation of condensate containing infectious organism. And it was said to be by the spread of fungal spores from nearby hospital construction in 1 study. All the 3 studies grew positive cultures for Pseudomonas, Staphylococcus, and Aspergillus from the intraocular specimen, but only 1 study, the study conducted by Pena et al., which said that the contamination was due to air conditioning system, could isolate the infectious organism from the environmental sample. For risk mitigation, the author suggested proper maintenance of air conditioning ducts and filters in operating theaters, implementing special prevention measures during hospital construction, such as air sampling, air filter purifiers, and replacing perforated ceiling tiles. And molecular biologic techniques may be useful in identifying source of contamination. In 5 studies, contaminated phacoemulsification machine was said to be the cause of transmission of endophthalmic pathogens. It included 40 eyes. The mean age was 65.5 years and the mean time of presentation with infectious symptoms were 9.63 days. The baseline visual acuity was counting fingers and it came up to 20 by 130 in the final follow-up. 4 of 32 patients, that is 12.5% patients, ended up with no perception of light. Here again, it was noted that the visual acuity in diabetic patients was much worse than in non-diabetic patients. For treatment, all the patients, that is 100% patients, received intravitreal antimicrobials. 45.7% received intravitreal steroids. 87.2% had to undergo vitrectomy and 12.8% had to undergo repeat vitrectomy. The cause of contamination was said to be contaminated phacoemulsification tubings in 4 of the 5 studies. In particular, G et al. Determined that all infected patients were treated using the same phacoemulsifier, Stellaris, Bosch and Long, which was found to have a drainage cassette that led to connection between the aspiration and irrigation tubes. All the studies could isolate causative organisms from the ocular specimen. All but one could isolate from the phacoemulsification machine. The most common organism was Pseudomonas species. For risk mitigation, G et al. Cautioned against reusing drainage cassettes when involving a connection between the aspiration fluids and irrigation tubes. Matters et al. Suggested flushing the tubing with sterile water after each procedure and using an ultrasonic bath and compressed air for cleaning prior to autoclave use. 2 studies, that is the study conducted by Huguenet et al. And Chaudhary et al., suggested that the cause of endophthalmitis was contaminated surgical instruments. The mean age of presentation was 77.1 years. The mean time of presentation in Huguenet et al. Study was 1 week and 1.3 days for the study conducted by Chaudhary et al. The baseline visual acuity was 20 by 80, which came up to 20 by 25 in the Huguenet et al. Study and 20 by 30 in the study conducted by Chaudhary et al. No patient ended up with perception of light or no perception of light visual acuity at final follow-up. All the patients received intravitreal intravitreal steroids. 8 patients and all the 8 patients belonged to Huguenet et al. Study had to undergo vitrectomy. No patient had to undergo repeat vitrectomy, initiation or evisceration. The cause of contamination was said to be the damaged blades by Huguenet et al. But it was also suggested that the damaged blades were not contaminated themselves, but their use led to ragged corneal incision, facilitating the introduction of microorganisms. Chaudhary et al. Identified residual viscoelastics on the surgical instruments that may have escaped the cleaning and sterilization procedure. Both the study demonstrated Staphylococcus epidermidis from intraocular specimen, but neither study could isolate organism from surgical instruments. For risk mitigation, Huguenet et al. Highlighted the need to pay close attention to techniques of manipulating the cornea when using instruments such as the diamond blade. Furthermore, fragile microsurgical instruments are prone to damage in the process of cleaning, and thus the benefit of using disposable instruments should be considered. The study conducted by Lalita et al. Incriminated contaminated topical anesthetic as the cause of endophthalmitis. The mean age of presentation was 59.2 days and the mean time of presentation was 59.2 years, and the mean time of presentation was 46.3 days. The baseline visual acuity was 20 by 810 on Snellens and it came up to 20 by 280 on final follow-up. 3 patients landed up with perception of light visual acuity. All the 13 patients received intravitreal antibiotics and vitrectomy. The causative organism was said to be Burkholderia cepacia, which was isolated from the vitreous samples and the topical anesthetic drops. And a clonal relationship between the 2 strains was demonstrated by PCR. Samples from the unopened bottle yielded positive cultures, therefore suggesting that contamination occurred during the manufacturing procedure. The study cautioned that pre-sterilized consumables can be vulnerable to contamination due to breach of sterility. The study conducted by Ramappa et al. Said that contaminated IOLs were the cause of endophthalmitis. The mean age of patients was 53 years and the mean time of presentation was 6.18 days. The baseline's visual acuity was 20 by 760, which came up to 20 by 210 on final follow-up, and 2 patients landed up with perception of light visual acuity on final follow-up. Here again, there was a difference between the final visual acuity of diabetic and non-diabetic patients, though statistical significance was not given. The causative organism was said to be Pseudomonas aeruginosa, which was isolated from vitreous and aqueous cultures from 5 patients and from intraocular lenses and their preservative solutions. It is important to note that the packaging of these IOLs was intact before opening, and all lenses that were used were not expired. All the intraocular lenses were from the same lot by one manufacturer, and this specific lot may not have undergone proper sterilization during manufacturing. The authors recommended obtaining cultures from various intraocular lenses as part of microbiological investigation for endophthalmitis clusters, and using molecular biology techniques such as enterobacterial repetitive intergenic consensus polymerase chain reaction to detect the source of infection more precisely. The study conducted by Su et al. Said that the contaminated autoclave solution was the cause of endophthalmitis. The mean age was 69 years and the mean time of presentation was 16.7 days. The baseline visual acuity was 20 by 600 and the final visual acuity was perception of light. 6 patients, that is 66%, and had a final visual acuity of no PL. The treatment included intravitreal antibiotics to 9 patients. Intravitreal steroids were given to 1. Vitrectomy was done in 9 and repeat vitrectomy was required in 8 patients. Enucleation was required for 2 patients. The causative organism was said to be Mycobacterium chelonis or Mycobacterium abscessus in all 9 intraocular specimens. A source of outbreak was not identified despite an extensive investigation. The author speculated that a contaminated solution used in autoclave was the most probable source of outbreak. The study recommended implementing perioperative sterilization procedures, including autoclave sterilization of instruments, periocular sterilization, sterile packing solutions, and sterile eye drops to prevent future outbreaks. The study conducted by Mirza et al. Incriminated contaminated cotton wool swabs as the cause of endophthalmitis. Mean age of presentation was 56.4 years and the mean time of presentation was 2 days. The visual acuity, the final visual acuity was hand movement, and 4 patients, that is 80%, ended up with no PL. In treatment, all the patients, that is 100% patients, were given intravitreal antibiotics with steroids. E-registration was required in 4 patients. The causative organism was said to be Enterobacter species in all but 1 intraocular specimen and also from remaining cotton wool swabs obtained after operation. The cause of contamination: cotton wool swabs in this centers were prepared manually from cotton wool, and there was a human error that led to breach in the sterilization procedure. The personnel had failed to remove the used indicator tape, and thus the drum containing the unsterile contents was returned to the operating room without being autoclaved. The authors highlighted the failure of staff to properly perform sterilization protocols and advocated for using disposable sterile sponges and carefully sterilizing all surgical materials prior to each operation. The current review identified 24 articles on endophthalmitis outbreak after cataract surgery. Consistent with the previous systematic review in this setting, the 2 most common cause of infectious transmission was contaminated intraocular solutions and phacoemulsification machine. The current review also demonstrated the clinical features of medical and surgical treatments after diagnosis of endophthalmitis and the worst visual outcomes experienced by patients with diabetes. The recommendation from multiple domains of transmission risk prevention and management to inform future guidelines were also summarized. Understanding the various routes of transmission is important for effectively managing and preventing the spread of pathogens. Our study demonstrated endophthalmitis clusters attributable to 7 different sources of contamination across 24 articles. The most prevalent route of infection transmission in this review was via contaminated intraocular solutions. Both compounded and manufactured fluid solutions pose a risk for an outbreak, especially if reused or not properly sterilized. The most commonly performed cataract removal technique was phacoemulsification. One study highlighted the possible contamination between the aspiration and irrigation fluids due to a connection involving the respective tube, which can be tested by injecting a dye solution into the aspiration tube. Contamination due to reuse of a surgical instrument, consecutive reuse of instruments, or inadequate sterilization was highlighted across several studies as risk factor for pathogen transmission. This underscores the importance of routine and rigorous surveillance of surgical materials involved in multiple procedures, especially the immediate irrigation of all structures with internal units. Investigation. Conventional cultural methods have a limited rate of detecting fastidious organisms. Thus, molecular techniques such as PCRs have been proposed. They offer the advantage of high detection rates even with less specimen material, and they also pose the ability to conduct cluster analysis to delimit the genetic lineages of isolates. Many institutes still face the practical challenge of obtaining samples, especially when the contaminated source has already been disinfected or discarded prior to the start of investigation. In such scenarios, the pathogen source needs to be deduced by identifying the common elements in the procedures and evaluating the plausible mechanism by which pathogens may be introduced, stored, and transmitted. Patient's clinical characteristics. There is evidence showing that post-cataract infection is associated with baseline factors such as diabetes mellitus, low visual acuity, higher intraocular pressure, hemosis, pupillary fibrin membrane, loss of red reflex, and reduced fundus visibility. In our review, there was a trend of patients with diabetes experiencing worse final outcomes than their counterparts without diabetes across the included study. Thus, diabetes may not only increase susceptibility to exogenous endophthalmitis, but also complicate recovery after treatment. Multiple risk mitigation strategies were provided by the author, which included improving the cleaning and sterilizing process, refraining from reusing surgical instruments or materials whenever possible, be aware of the possibility that pre-sterilized products can also be contaminated, implement formal inspection and control measures to scrutinize practices that may increase the risk of pathogen transmission, use molecular biologic techniques for detection of pathogenic agents, and obtain official statistical data on hospital infections to inform preventive measures. There were certain limitations to this study. Evidence reported in this review was of low or very low quality according to the grade evaluation. Study protocols were significantly different between articles, leading to variability in treatment protocols, sterilization standards, policy on instrument reuse, and resource allocation, among other factors. This study is also limited in part by publication bias that may have precluded certain endophthalmitis clusters from being reported in the literature and consequently being concluded in our study. In conclusion, cluster of infectious cases after cataract surgery are rare but have devastating consequences for patients who have serious ophthalmic complications. A large diversity of exogenous microorganisms may be transmitted to patients undergoing cataract surgery via various routes such as intraocular solutions, phacoemulsification machine, operating room environment, surgical instruments, topical anesthesia, intraocular lens, autoclave solutions, and cotton wool swabs. Thank you.
Yeah, thanks Nihali for that your extensive presentation. I will just sum up few points which are important as far as source of infection is concerned. The first is intraocular solution, then phacoemulsification machine, contaminated surgical instruments, IOLs, autoclave solution, and cotton swabs. Intraocular solution and phacoemulsification machine being most common causes. Pseudomonas, most common organism isolated in most of the clusters. Diabetics experiences worse prognosis. Intravitreal steroids given along with antibiotics give better visual prognosis. So this is the crux of this review. I just want to have comments from all the panelists. Bende sir.
Maybe I think we'll have a Sabyasachi's input first, looking at analysis, very all these studies, different study protocols, what she has rightly mentioned, value and importance and evidence as far as this review article is concerned.
Sen Gupta, you can give your comments.
Sabyasachi.
But at least once you got the chance to speak first.
Everybody runs off otherwise. That's how
Yes, sir.
Yes.
Okay, so I'll make a few comments in that sort. So, as when we have review articles, it's quite difficult to, sort of come up with any particular comments on that study. Couple of things, one is the route of transmission is always difficult to find, and the organism is sometimes even more difficult to find. So, so that's sort of something that we should always remember. And, this article, of course, mentions itself. Other thing is, when people operate in clusters, you can get infection in clusters, right? So generally, cluster endophthalmitis happen in places where there are large volume surgeries happening on a daily basis or on a regular basis. So, that is something that we should also sort of remember. So, such centers should always have a very high volume of suspicion. Say even two cases a day should probably considered as a cluster. At least, should be sought answers for as to why 2 cases have happened in one day. Because, if you don't do anything, you might have 10 cases the next day. Something which has not been discussed at all in this paper and probably not reported by most studies is, the influence of intracameral antibiotics. I'm sure our panelists will tell us a little bit more about their experiences and whether they use it and what their views are, especially to prevent cluster endophthalmitis. So there are a lot of large articles now from Arvind which have come out and shown that use of intracameral antibiotics reduce the incidence of endophthalmitis and particularly don't lead to clusters. Some other things like particularly about sterilizations, like whether flash sterilization can lead to increased risk, because remember that these are high volume operating centers. If you do 100 surgeries a day, it's almost impossible to have 100 operating sets, isn't it? So even if you have 20 sets, you're going to reuse them about 4 or 5 times. So what happens in between surgeries is flash sterilization, where you run short cycles. Whether this can actually increase the risk of endophthalmitis is something that they have not told us. So it's probably a checklist-based approach for instrument cleaning or autoclaving, or maybe how intraocular fluids are randomly cultured on and off can also be sort of mentioned. Overall, from the methodology point of view, so listeners should know that there are 2 different types of reviews. One is systematic review, and other is a narrative review. So this is actually an example of a systematic review, and a well done systematic review overall, where you look at 2 important things. One is you have a hypothesis before you're beginning. So what is the study question? It is very well defined, and what are the search strategies you will use to include studies, and so there should not be selection bias in sort of including studies. And so there should be no the author should not have their own bias reflected in the way the review is presented. So that is an example of a systematic review, and this is well done, where you look at the they've used the Cochrane tool for bias detection. So that's easily available, you can all Google it up. And also they've used the grade protocol, or the the grade methodology for looking at how strong the evidence is from each study, and they clearly say that most studies have a very low level of evidence generated from them. So that is these are 2 things which are very important to do when you're doing a systematic review. Then also follow a Prisma checklist, which can help you actually write that systematic review, and this has all been followed here. So these are some examples. I mean, this is a good study in terms of the methodology in the way it is done. Unfortunately, the level of evidence which is there in literature for cluster endophthalmitis is not that high. So the authors did the best with what they could. So overall, these are some of my sort of inputs. I would love to hear input from PB sir and everyone else.
Dr. Bende, sir.
Thanks, Sabyasachi. And let me first outset thank MOS for invitation and having me here. It's nice to be back with all familiar faces once again. So, it's a very important issue. As an article, I would say Sabyasachi has, I think, analyzed, but as a topic, I think we need to look at it. It's basically probably it's initiate discussion where how you can prevent it, how to handle it. I think that probably will, from here you can go forward. And nobody would like to have endophthalmitis, forget about cluster. That's a very, very important thing. And yes, there is no proper definition what is meant by cluster, but yes, 2 or more in a same setting and a short period of time, probably you can define as a cluster. People have talked about 6 cases or 8 cases or anything more than 3. So yes, anything I think in generally acceptable is as more than 2 or 3 cases in a same sitting, probably in a short period, and not necessarily that you need to have just in a same day. you can have some consistently, it can happen over a period of time in the same setting. You get a one case today and then lull between 8, 10, 12 cases, and some other day, another one case, another one case adds on. But I totally agree what Sabyasachi says. Even if you have one case, your antennas should go up. Look for, analyze for why it happened. And lot of factors are given here. They talk about cluster, but other patient-related factors are also there, which they have not discussed here. So probably those also everything, and staff-related factors. You have your assistant, other OT staffs. If somebody is having already carrying infection, those factors obviously not discussed. But when you can have each institute have their own protocol. If you land up in this mishap or untoward incidents or endophthalmitis per se, you call it here, can have a checklist to go through that systematic way. So that basically, again, it's a fact-finding mission. You are not going to point finger at someone. The thing is that once you do that as a routine, it will become as a reflex act, and you know where things are going wrong. Probably you can minimize the risk or avoid subsequent cases. I won't say you can avoid endophthalmitis at all, but probably risk definitely can be minimized if we can identify factor. That's very, very important when you're dealing with. I think we'll add on with the time, let others talk, and then.
Preetham, I just want to know how do we manage once if we find out that there is a cluster of endophthalmitis? So how do you really go ahead with the investigation or the management of such cases? So
yeah, so I think that's a very important topic, because if it's just a single endophthalmitis, then it comes down to just managing the case. Although a single endophthalmitis, still the onus is on finding the cause from where the bug came. But when it's a cluster, then it gains a larger proportion, because then you have medical legality involved. You could be having the media involved. It just snowballs into a larger problem. So when it comes to a cluster, then you have to have more people involved. You have to find out the cause, because like what Sunny said, that if you had a cluster now, you could get a cluster in your next OT again, because the same, unless you find what happened, what went wrong, it could just happen again. So when it comes to cluster endophthalmitis, it involves a lot of things. You have to find out the common cause, probably shut down the OT. Shutting down the operating theater in an institute would mean a lot of implications for that institute. So in that situation, a cluster endophthalmitis definitely is definitely a bigger problem than just probably one-off cases of endophthalmitis. But having taken that question, I have a couple of things which I wanted to discuss. So one thing is, I wanted to ask, now there are all such esteemed panelists here. I just want to ask a random question to all of the people here. Does anyone on this group, in their respective institutes or in their respective practices, have an upper cap of how many cataract surgeries should be posted in a given OT? Let's be honest, I don't have.
Well, I think, looking at our practice, obviously we don't reach that number because the stringent protocol what we follow. But AIOS has given definite guidelines.
Yes.
How many cases you should be doing in each session and number of surgeons if you have. And I think we recently had a meeting for prevention and to create a guidelines for prevention of endophthalmitis, like I think a couple of months back. And that new guidelines are coming up. And IJO also, I think the February issue, or is it come already in that February issue?
No, I think it's there in that.
I think they are coming up. Those
Yeah.
guidelines, and I think hopefully that everybody will follow those guidelines.
So
I think some 20 cases.
Yeah. So why I brought up that question is, I'm attached to JJ Hospital Institute, and I have dealt with at least 6 or 7 clusters in the last about 10-15 years. Now, one thing which I've observed in all these clusters is these clusters classically happen between the months of November, December, Jan, and Feb. Now, these are the months, if you see, I mean, all of us will agree, is the time when we do maximum number of elective ophthalmic procedures, or cataracts, you can say. Our cataracts are maximum in these times. So probably these are the times when we are doing maximum number of cases. and that is where our protocols are maybe failing. That is one possibility. Except for two of these clusters, all the other clusters were from camp surgeries. Again, camp means a situation where these surgeries are done in volumes. The other two clusters again were from charitable institutes, again places where cataracts are done in volumes. And so what I'm getting to is, another aspect which I want to hear, what I want to say is, we always talk about diabetic patients and how much risk factors, we are talking about our sterilization. I don't see anytime people talking about our staff, and what is a burden on them. I mean, if you're doing a camp where 100 and 200 surgeries are operated in a day, are we really going into the back rooms and seeing how much of fatigue it is on our staff members, how many hours our staff members are working, when they are having their dinner, their lunch, how many hours they are sleeping between two camp surgeries on 2 consecutive days. This is something which I don't know whether even in the when we discuss the AIOS, I don't know whether we've touched on this point. This was something which I wanted to say, but because of lack of time, I think we didn't touch on these points.
So, I think last meeting we did discuss this one.
Okay.
And we are looking at it because surgeon is blamed for this, and surgeon is busy operating, and behind him all these things are activities going on which are equally important, which surgeon do not have control, he is not aware of, and that's why we recommended this time we have a parallel other person totally in charge to overlook all these activities, and it's very, very important, and he should be held responsible. It's totally he should be accountable for all these activities, dealing with what activities what you are just exactly suggested. Surgeon job is he is operating, instruments are on the table. Yes, he cannot wash his hand out because of course he is the head of the team. But when he is concentrating on surgery, team has to work around, and we have to have somebody from the team taking care of all these activity, including, of course, now I think government has totally banned makeshift OTs. It has to be in a proper theater complexes. Fortunately, those camp practices has gone down. You can just sort of joke apart what Pritham said, like 500, 600,000, and there is a record 1,500 cases doing, or some cases in a day by one surgeon, and it used to be like a conveyor belt. And I remember when during my MBS days, that next day when the patch is open, 3 patients never had a surgery. In that conveyor belt, they went just out quickly, just somebody give blocks, somebody keep things ready, and without surgeon doing cataract surgery, patch was put and patient was sent out, realized next day morning. No, I mean, that's exactly what you say. Human error is bound to happen when you have such a huge turnover. It does happen. Okay, so it's equally important. And what typical case scenario, what in a presentation she described about like a cotton swab, not removing the previous sticker, putting the cotton ball, and tray goes because everybody's in a hurry without realizing things are not done properly. The checklist has to be there. Is somebody, a person, independent person supervising all these things is extremely important. Rather, that is more important than actually doing only cataract surgery or good cataract surgery in particularly this type of setting. As far as management per case, if you look at it, whether it's cluster or other, regular endophthalmitis, management per se does not change as long as you pick up those cases on time. Intravitreal antibiotics and other steps are exactly same. But what happened here, you have probably same organism you are dealing with so many cases. So you have to be act, and only thing is the sheer volume number of cases, probably magnitude is more. You are again, mental fatigue sets in because you start feeling guilty. Okay. So your common sense stop working. So again, you need somebody helping out these cases. But yes, case to case management does not change. But what changes here is what Pritham has described, because other issues which are connected with this cluster, like media will be right on your head, government agencies, they want somebody's scapegoat to immediately to show somebody that who's responsible, okay, rather than actually doing proper work. Definitely, I would say even if 3, 4, 5, I mean, you have a number of cases more, maybe 5 or 6 cases if you have, whether it's institute or not, first thing I would recommend you shut down the theater. Definitely. It's very, very important. Landing on huge problem later on, analyze each and every parameter. look into everything, thorough investigation. Unless everything is clear out, I won't recommend restarting the theater. Yes, there may be a significant loss, but I think it's worth having that loss rather than landing up losing many more eyes. And most of the cases, when you see this series, and that is true our Indian scenario also, that cluster endophthalmitis, most of the cases, final outcome is really not that good, as against you see isolated cases here. Also Indian scenario, because of patient, again, poor hygiene, the soil contamination, other thing, fungal cases, fungal endophthalmitis in a cluster is much, even otherwise also fungal endophthalmitis is more common in Indians and or Asian setting, I would say, compared to when you look at American publications or European publication. In fact, there are no fungus at all. Most of them are like our Asian countries.
Sir, any comment on simultaneous bilateral cataract surgery being propagated by Steve Arsenault, and people are doing now in India also? So what is the AIOS take on that? And what is your personal
AIOS
comment?
I think AIOS says no, definitely. See, I mean, again, you look at a theoretical aspect. If you take a due precautions, you treat each eye as a separate one, independent one, finish one eye, patch and pick other eye totally fresh equipment as a independent fresh case, as if doing a new case, again, cleaning, draping protocol, following everything, theoretically speaking, is fine. But none of us are 100% sure that even if your sterilization protocol, how strict or stringent you may be, there's always a 0.00001% risk is always there. What you want, actually, that also should not happen in this case. And that's one more reason, given option, I won't do both the cases together, both eyes together. And I think AIS protocol is like that. Definitely, they are not recommending, rather directly they said no to doing both eyes in same city. People are doing for sake of convenience. See, before, again, looking at just following whatever is happening in European and Western literature, our lifestyle is different, environment is different. Look at pollution, look at other factors. All those things we need to take into account before directly just following or copying things. Our patient profile is totally different.
Absolutely, sir.
And another point is most of the phaco systems are now closed irrigation systems. The positive infusion and closed irrigation systems. So we have to be careful from that aspect also. In the past, there used to be systems where the cassette would just collect the fluid, and there would not be a closed irrigation system. But now with a closed irrigation system, I think we have to be more careful. It's like they say, technology is a double-edged sword. Although it has upped the game in terms of your efficiency of doing a phaco surgery, but at the same time, it could be a downfall and result into clusters. If you're going to use the same cassette again by just changing the phaco tips and things like that, then you have to be extremely careful.
Not only that, one step ahead, again, it's a part you want to call as a commercial issue or whatever it may be. Sometime when you restart machine and using the same cassette, the fluid circulates in such a way when you shut down the machine that both the chambers get mixed up, infusion line and whatever irrigated fluid which is coming out of the eye, and that is much more dangerous. So people are again trying to circumvent that, like switch on the machine and keep it on, don't switch off till you finish all the cases for a day. Various ways people are trying, but yes, that's a major risk.
So, sir, do you recommend that in our scenario, we have these systems with disposable cassettes? So for every patient, we should be
not viable. Problem is, see, ideally should not be. Ideally, we should not be. But for each case, separate set, it's just not viable. Just see, I mean, no, you even having a Western people, American also having a difficulty now. They are also rethinking about whether we should go back to their reusing thing. It's just not practicable. Then cost will go so high that I think people will not be able to afford at all surgeries. You just can't do. So we have to find ways. I mean, officially you cannot write. Another problem is if you reuse, again, company will wash their hands out. So because it is written as for single use only, and because of that something happened, and because you are reusing, that's another. Then company washes their hand out. And once he's right a single use and patient come to know, and suppose unfortunately something goes wrong, he goes in a court, nobody can save you. Okay. So legal point of view, yes, nobody should use. But practical point of view, nobody can afford to use, except probably isolated 1 or 2 surgeons. But then when they charge maybe 1.5 lakh, 2 lakh per surgery, if they are charging, fine. If you want to do, we are talking about CAM surgery, we are talking about surgery, doing surgery in 1,500, charge somewhere around, maybe around 5,000, 7,000 package. You just cannot you use a new set for each case. Unfortunately, that's a practical reality.
Sir, there was in one of the discussions, even one point came up where what happens is, when a particular company upgrades the machine, it discontinues service on the previous model. Okay, so this point came up that, suppose if you are using a refurbished older machine, where say it's a reusable cassette and it's not a closed irrigation system. Now, if in such a scenario, you got an endophthalmitis and there was a medical legal case, what if it came to a situation where the court of law asked you, why are you using a machine which is no longer supported by the company? So there also the operating surgeon could be in a fix. If you're using a refurbished machine which is no longer supported by the company, that also could be held against you. So that also is one point which you have to look into.
And many times we use intracameral solutions like pilocarpine, lignocaine. Our BSS also sometimes they are available in glass bottles. Do you recommend them to autoclave and use them for safety purpose?
No, autoclaving this bottle does not sterilize the solution inside. Let me make it very clear, because those are sealed bottle. So it's like they just give you pseudo sense of security. If packaging is damaged, that's why before you use the solution, what you need to look at it, look at the packaging, look at any cracks, look at the seal is not tampered, all those things. And the commonest thing what I saw is, see, whenever you open new bottle, you have to wipe that rubber cork before you put your needle or syringe or whatever it may be. See, a lot of times your OT staff thinks when the metal chip they remove, they think it's sterile. And it happened with our intravitreal injection also, particularly when they open the cap, they think it is never sterile, it is exposed, it is clear. So we have to either whether alcohol swab you want to use or whatever way you want to, always clean that one, spirit or alcohol, whatever you want to, before you put your needle in. But this like autoclaving the bottle, actually you are not really sterilizing solution inside. It just gives a pseudo sense of satisfaction.
Sir, I just want to know, in cluster endophthalmitis, you said that the visual recovery is not that very great. So what are the factors which actually would point towards a better visual recovery versus a worse visual recovery? And second, this study did not really comment about these steroids, but as highlighted with the speaker, wherever they have used steroids, the outcomes were better. So is there any role of steroids in all cases of endophthalmitis?
You use steroid is definitely using topical steroid. Most of the cases we use, particularly bacterial endophthalmitis. Fungal is again controversial. Most of us do not like to use. Sorry?
Intravitreal also.
Intravitreal, we are all bacterial endophthalmitis definitely ways you use intravitreal steroid, systemic steroid, topical steroid, systemic if necessary. But definitely topical intravitreal steroids are being used when you are dealing with a bacterial endophthalmitis, not with a fungal. But and the fact you get a cluster endophthalmitis because quite sometimes organisms are much more virulent than see most of the cases what you may have that presented today as pseudomonas. We know this. So it's or soil contamination, like this one, Clostridium group of organisms. So these are because organisms are definitely much more virulent in a cluster. Sometimes they are not treated on time because camp setting, what you said, patients are operated and sent home. By the time they report, is already lost the timing. That's the thing. And third thing is again, Officially, nobody agrees, but most of the time they are suppressed also initially. Nobody wants to come out that I had a cluster. So nobody wants to say that one. Unfortunately, that also happened. And it's a human nature. I won't directly blame anybody, but does that happen? Nobody wants to like to call my case as endophthalmitis. We talk it as a like a severe inflammation or something like that. We try to put word, but we don't. No cataract surgeon will say I had my case I had endophthalmitis unless subsequently proved. Okay.
And what are the factors that help improve the visual acuity in these cases? Is there
No, again, see, parameter guidelines are exactly same. Early detection, if you get, you pick up the organism and treat with appropriate antibiotics and of course supporting therapy. If you can do that, that's every case. I mean, it has to be done, but circumstances, situation probably may not allow you to do that in this situation, these settings rather.
okay?
I think about the steroids, I think it's like Sir said, I think it's very important. Steroid forms a very important part of the treatment of any bacterial endophthalmitis, because it's it's the antimicrobial which takes care of the bug, but it's steroid which is responsible for the functional recovery finally. It's if you're not treating it with steroids, then you will eventually have ciliary body atrophy, hypotony, phthisis. So steroid, I think, is a very important part of treating endophthalmitis as long as it's not fungal. In fungal endophthalmitis, it is contraindicated.
I just want to ask one question to all the panelists. I have seen few surgeons preserving BSS and intracameral solution for surgery, for investigation if something goes wrong. Is it advisable? And if at all it is
Actually, we do that one because quite sometimes generally what we do is like whatever use that particular cases, you pack in a separate bag and keep at least 24 to 48 hours. So you have a first review next day or subsequent day, after within 2 or 3 days, nothing happened, then to discard it. Okay. It makes sense. But yes, theoretically, again, one more practical issue is once you open the cap, there is a possibility it can get contaminated later on also.
Yeah.
Okay. But if you have a same organism coming from your like a solution, irrigating solutions used, and patient is having your culture ACR vitreous tap, probably that what from where it came. That way, that is recommended actually.
Okay.
But then space issues, and particularly when again Sabyasachi and Pritam was talking about when a very high turnover number of cases, where you're going to store this thing. And also same irrigating solution bottle you use for 3, 4, 5 patients. You put a one VSS ringer lactate bottle for maybe 5 cc bottle, and 5 patients, 6 patients, you finish with one bottle. So because of again practical reasons, again not criticizing anybody, but that happens. So again, then the practicality is an issue here.
Somebody has asked a question about intracameral antibiotics. Whether it is useful for preventing endophthalmitis.
Yeah.
We had a lot of discussion on this even on the AIOS forum. And I think on various forums, this discussion has happened, and there is a lot of even now evidence in literature. There's a meta-analysis also. So I think the general consensus is that, probably it may not exactly help in preventing endophthalmitis, but it is definitely useful in lowering the manifestation. That means if you had an endophthalmitis and you had given an intracameral, probably you will get a milder clinical picture. So that is what a lot of forums which at least I have appeared on and discussed with, that is what people are of the view. So your view, sir, Dr. PB, sir?
Yeah, that's the only view is I am hesitant because of drug like your resistance. You are inducing drug resistance, one thing. Second thing is I would err more on a stringent protocol being followed for sterilization and your O2 protocol and everything, rather than giving intracameral antibiotic, because somehow you start giving and you just feel a false sense of security. People go more concentrate on giving intracameral. Just because having a 1 or 2 cases or 3 cases of endophthalmitis, and for like a remaining like a 10,000 cases, their intracameral antibiotic is going on. Contact period is very, very less looking at it. Like a duration, the drug stays in eye during that time. Okay. So what I would suggest basically is more important is your concentration on your sterilization protocol, concentration on your surgical step, ensure your like a section is properly closed. Somebody has posed the question, like I have a very low raise, or rather I would say, if section is ensure repeatedly the section is self-sealing, watertight section I would may put it in, but not airtight. And if is not, do not hesitate taking 1 or 2 sutures. If patient is not compliant, patient is going other dusty weather, just tell them, we have to counsel them. And particularly that I'll concentrate more, because again, that's another article with a faulty instrument, particularly blade, ragged blade. So infection was not because of blade was faulty, but because of section was not well opposed. So naturally, subsequent leak through an organism entering in the anterior chamber with that. So take care of all those things, and probably that itself help you minimize your incidence of endophthalmitis. Intracameral antibiotic, yes, a lot of people are giving now. More and more people are going on it, but drug resistance, we are going to face more and more with that also. Really difficult to treat those eyes now, because we have a few cases, extremely difficult. No drug, I mean, every possible drug. We have fairly good microbiology lab, and there are at least 2 or 3 patients. We tried all, including our cholesterol and all those things. Organisms are resistant to everything. Just cannot do anything.
So more
Sir,
going
sir,
towards.
can I ask a question? The recent ASCRS 2021 endophthalmitis survey has shown that intracameral usage has increased. But at the same time, they have shown that the preoperative and the postoperative antibiotic usage is questioned. Some of them have stopped using preoperative antibiotics and postoperative antibiotics. So what is your personal take on that?
We don't use preoperative, postoperative antibiotics at all. We ensure that patient hygiene, we ensure and sterilization protocol is maintained and have a close follow-up. We don't use.
So what about
There is no evidence now. Strong evidence that it will prevent. But what we are particular about, pre-surgery contact time of povidone iodine, at least that 3 to 5 minutes contact time. It goes equally good with the 3 days antibiotic prior to surgery and povidone iodine on the table 3 to 5 minutes. I think it's as good as same. And
so
medical very particular about.
Medico-legally, systemic antibiotics and preoperative antibiotics can be avoided?
Yes. Yes, there is no evidence to that. But what happened, maybe to word of caution here, particularly people, those are doing a topical anesthesia surgery. And if they are using lignocaine jelly, before putting your povidone iodine, wash that jelly. What happened? You jelly over that you put povidone iodine, it doesn't reach your conjunctiva at all. Okay, so just a word of caution there. Jelly just coating your ocular surface, povidone doesn't reach there.
Yes, sir, I'm in a private practice, so I think probably I have only seen occasional case of sporadic endophthalmitis. So do we really treat these cases, investigate and treat these cases similar to clusters, or we can be a little easygoing on?
No, not easygoing, but what you need to do is you just revisit your entire sterilization protocol. Okay, that is what you need to do. See, you are not worried about other media and all those things and those issues and what Pritham was talking about. But what you need to do is you do not want to have a second case happening like this.
Yeah.
You go back, revisit your entire sterilization protocol, your OT air conditioning, what we are talking about, your staff, whether their hand hygiene, whether somebody is having a cough, cold, your assistant, your instrument equipment, your autoclave system, all those things you'll need to look into it as a routine. That's why, like, you make something like one pro pharma checklist, and if anything lands, this is what I'm for. What happens is not private practice or institutional practice or everywhere. You set the system initially. Things are working fine. Over a period of time, complacency sets in. You know things are working fine. You do not know somebody, your assistant. You are not going to go in a sterilization room. You train somebody, that person is there, and you rely on that person. He is a key person for you. But something, he become complacent, or he leaves and someone else come there, he can overlook certain things. So what happened? Frequent in between cross-checking, And if something like that happens, revisiting entire protocol once again, probably that will help.
So I think
It happens. Somebody, we were discussing some of other, like you are setting, somebody had this problem. Every 2-3 weeks, one case is coming. Every 2-3 weeks, one case is coming. So you don't define as a cluster, but person was cautious enough to understand that something is not right, and he had checked everything. Nothing he could point to. The person says, "Let me check my surgery videos," because patient enters inside and then goes out. Everything is video recorded, and then turn out to be head cloth or something drape we put that was not being changed. Chalta hai. So sometimes soak, sometimes not soak, and those cases land up into trouble, something like that.
yeah, I think checklist is very important. We should not rely that we have experienced staff. They can also go wrong. So checklist is something which I think even I follow.
We all are human, so it happens.
So I think there was one more question about the type of incision, whether scleral incision versus corneal incision. So is there any difference in the incidence of endophthalmitis?
Looking at the literature, yes, with a clear corneal incision, there is a higher incidence of endophthalmitis compared to sclerocorneal or limbal incision. It is proven. So, but as long as I would say, because see, with the corneal incision now, with the newer IOL, since incision size is also very small compared to what used to be previously. So as long as incision is watertight, I would say on the table, you are fairly safe. Okay. Only thing is, but then these incisions are get prone. Suppose you have to take a post-op precaution of injury or something, or excess squeezing. That is one thing. Also, when you have this wall incision, probably when you close the case, intraocular pressure should be marginally higher, because the way the incision is designed, that with positive pressure inside, that inner lip presses against the outer lip, and that is what closed the wall. If I left hypotonus, the chances of contamination, risk of infection is definitely high.
Okay.
Is there any role of intracameral antibiotics, suppose to take care of egress of the fluid immediately after the post-op? Suppose if you are putting intracameral antibiotic, take care of egress of fluid if you have corneal incision.
I don't know exactly, but I see its risk is as same as it is. Egress is fine, but basically if section is closed, watertight, why it should come out? The fact if it is coming out egressing, that means the wall is not working.
Yeah.
I don't know whether I answer your question. Sorry. So
yeah, because one answer to using intracameral antibiotic is that if suppose usually these incisions are on the temporal side, and if patient happens to sleep on that side, the incision may leak. To take care of it.
Yeah, now you are talking about later on. What happened then, that antibiotic half-life is hardly half an hour, 45 minutes in that thing. So it does not protect you for later on. It will protect you, probably give like during your surgery, something would have entered left inside, and that's what intracameral antibiotic will help you. It just get washed up around 30-40 minutes.
So we are talking about the only moxifloxacin per se that has a shorter half-life, or even the other antibiotics?
Most of them are. See, intravitreal antibiotic is different. Intracameral, your currents flows, they're much faster pharmacokinetic. They don't see, basically you may be able to trace antibiotic for a longer, but look at the concentration, half-life basically, and looking at MIC and other thing, probably it may be traced, it may be available, but whether it is that concentration is effective enough to prevent subsequent.
True. Yeah, Joshi.
Yeah, are there any questions in chat box, Ashwin? Do we have any queries?
Very well discussed.
So I think there is, Dr. Mandar has said something, that important factor is periocular source of infection and infection nidus like blepharitis. So any comments on that, sir?
That's exactly what we were talking about, patient hygiene and then periocular tissues. That's what is in our Indian scenario we talk about. So that's why doing both eye surgery, I said, is so you need to look for, particularly myomitis is so common. Look at it, ensure you clear all those things before taking patient for surgery. Definitely.
Yeah.
You have to take care of. And of course, most of us stop doing, I think, syringing now, but at least Roplas can be done. But that should not be done on a day of surgery. Probably at least do a day before also.
The role of conjunctival swab, sir, nowadays?
But routinely, no, I don't think routinely anybody does now. Just we look at Roplas, eye, but we still do cases. They are one-eyed cases where you have a rather doubtful hygiene, and obviously you see contamination or something. Other eye prosthetic, I suppose you have probably, again, I would prefer conjunct, because look at other hygiene, and I would tell patient to stop using prosthetic eye shell for next few week or two till things settle down. Particularly what happened, again, lot of debris collects under the prosthetic eye shell. A lot of people, they just do not take it out also, and a lot of discharge will be there. That itself can be source of contamination. So ensure if you have prosthetic eye that is properly taken care of, that socket is healthy before you take the other eye for surgery.
Yeah, I think we have already overshooted the time.
We can go on and on, I think.
Yeah.
It's a never-ending topic.
Yeah.
Anyway, very fruitful discussion has gone up. Fantastic the way it was conducted. And I think Pramod has given lot of inputs, valuable inputs. Pramod, Preetham, and of course Rajesh has been conducting very well, and Sabyasachi also. Would you like to
Ashwin,
questions for Rajesh?
they want to play their video, I suppose, in Todd. Ashwin, are you there?
They want to play a video. Yeah.
Sayed sir, can you play the video, please?
Yeah. Yeah, please.
So before we finish, I just want to ask one more question, is that when we are investigating these cases of endophthalmitis, we usually subject the samples for routine smears and cultures. So, and many times I have seen that in sporadic cases, we don't find the organism. So is there any role of PCR? So do you think PCR is more important in investigating these cases?
PCR definitely helps. PCR definitely helps, but then you have to be a little bit cautious, because false positive, false negative, those are the issues. But now it is accepted if you have PCR positive, and then again clinical correlation, obviously you will do. So that definitely is taken as a positive culture.
Thank you.
Yeah, I think it was really a wonderful discussion. And on behalf of MOS, I thank Dr. Pramod Benge sir, Dr. Preetham Samant, Dr. Sabyasachi for sparing their valuable time and highlighting on various aspects of endophthalmitis. I also thank my resident Dr. Nihali for her presentation, Dr. Parul Vaishal for guiding all the way, and of course Dr. Taswala for his wonderful initiative, and Intor for the technical support. Thank you so much and good night.
Thank you very much.
Thank you.
Have a nice weekend. Thank you.
Yeah,
So request you to please stay on with the cameras. We'll
Yeah.
just have a quick picture of you all.
yes.
Presentation.
Sayed,